everyone, welcome to LiveSmart Overactive Bladder Pelvic Power Hour with Nina Barnett and our guest speaker, Jennifer Long. We're going to go through a few housekeeping items. First, your audio is automatically muted. We do ask that if you do have questions, please place them in the Q&A function at the bottom of your screen, and then those will be asked at the end of the presentation. This event will be recorded and it will be sent in an email with a follow-up link so that you can view that whenever you like. Our guest speaker, like I said, is Jennifer Long. She's our Director of Rehabilitation Services here at McKenzie Health System, and she'll be happy to share with you today and answer any questions that you might have. Jen?
Okay. I'm going to hit my share screen. Gonna hit my PowerPoint here. And is that looking good, Nina, on your end?
You still have to hit the blue share button.
Oh, Lord. All right.
It's okay.
I know. Everyone's so patient with me. There we go.
There you go.
It's looking good?
It is.
All right. So all set to begin? People
You
are,
are.
or do you want me to wait a moment?
Nope, go right ahead.
Okay, thanks everyone for joining. Again, my name is Jenny Long. I'm one of the PTs here at McKenzie. And we all know that bladder trouble can affect us throughout our lives. And so this topic is, the discussion today is going to talk about some bladder basics, some things that can go wrong with the bladder, and how you could do some things at home or self-help techniques to address those issues. So the objectives today for this webinar are to understand what's normal for some normal bladder functions, and then conversely, what is not normal. We're going to learn how you can have a healthier bladder with self-management techniques, and also learn when your symptoms need medical attention. Some bladder basics, we all have one. There are some cases where people don't have a bladder for certain reasons, but generally we all have one. And it follows the basic strategy of it fills, it stores it, and then we have to empty it. Many factors can affect normal bladder function. Some exercise can help bladder problems, which we'll learn today. And then some self-help techniques are also available that can help symptoms. Basic bladder functions, there's some listings here, and one is that it can hold up to 2 cups of urine before it needs to be emptied on average. The average voiding, you'll hear that term voiding, that's a medical term for peeing. So the average time to void urine is about 6 to 8 times per 24-hour period. We know that bladder capacity decreases with age, which can cause more frequent urination, but you should not have to go more often than every 2 hours. Urine should flow easily without effort. You should not rush or push your urine out, which I know we've all done at times, but on an average, we should not be doing that. And for nighttime voiding, 1 to 2 times per night is considered normal to have to wake up and void of urine. So let's talk about what bladder incontinence is. So bladder incontinence is the involuntary loss of urine when you're not expecting it or you don't want it to. We know that urinary incontinence affects both men and women. Studies show that 1 in 3 women will suffer from urinary incontinence of some kind, and 1 in 10 men will suffer from it as well. Urinary incontinence in women is often blamed on pregnancy. You hear people say, oh, I've had a lot of children, or this or that, or had a tough labor and delivery, and maybe that's why. And certainly that can contribute to it. But we also know that women who have not been pregnant or delivered a child also suffer from urinary incontinence. So we can't blame it all on pregnancy. We also know that constipation and straining of your bowel may also worsen urinary incontinence. So it's important to address bowel issues if they're present as well, because they can contribute to the urine incontinence. And a side note, people can be incontinent of bowel as well. This isn't going to directly address that, but know that that can be a problem as well. Let's look a little bit at anatomy, just to give you an idea of what we're talking about. So we are going to show some pelvic things as well in the next couple slides, but this is a front view of your kidneys and your ureter. There's a lot of things missing there. We don't have our stomach muscles here showing, or a lot of the other organs, including your intestines. But most of us have 2 kidneys, one on each side, so a little bit high up in the back area. And that's where our urine is filtered. And then we each have ureters, one on each side from each kidney going to the bladder, and then the bladder is stored. The urine is stored in the bladder, and then we eventually there's nerves in the bladder, and we get that signal to our brain telling us our bladder is full and we need to void. That's just a basic overview of the anatomy of your kidneys and bladder. Next, we're going to show the specific pelvic area. Again, I think it's helpful to have a picture of what we're talking about. This is a side view, like if you're kind of cut in half and looked at the side of your lower abdominal area. So starting in the back here, you have your spine and your tailbone or your coccyx. This would be the bottom of your intestines into your rectum, where your bowel would evacuate from you. This here in the middle, hopefully you can see my cursor. This is your uterus for those, and this is a female model. Men obviously would not have this uterus. And you can picture if you had if you were pregnant and this uterus was growing, how it could put pressure on the bladder, and hence that's one of the reasons when we're pregnant we have to go to the bathroom more often, because that increased pressure on the bladder from the size of the growing fetus. Then here's the bladder itself, and then your urethra is this tiny little tube right here where the urine would exit out of our body. So a little bit of anatomy to give you an idea of what we're talking about. The next slide is musculature. I know it's kind of small, and I have a bigger one later on that will show you, but this is a top-down looking at your pelvic floor. So this red area are your muscles, what we call your pelvic floor. So it's a lot of muscles, ligaments, tendons in this area that support the pelvic floor. This is the back. This is one of your vertebrae here. On these other side, your ilia or hip area bones. And then you have your rectum and your vagina and your ureter. This is a bottom view looking up from the bottom. So this top one in reverse coming from the bottom. And again, you can see all these red areas, which are the muscles we're going to be talking about, and how those can, how you can affect those to improve the strength to help decrease the incontinence. Next, we're going to talk about the types of urinary incontinence. There's a lot of information here. I'll try to simplify it as best I can, but if you have questions, feel free to jot those down or put them in the Q&A. So the types of urinary incontinence, the first one here is called overactive bladder, or OAB. And those symptoms are increased urinary frequency and maybe urge incontinence. You can have one or both. So this is like, I have to go to the bathroom really frequently, and maybe when I get the urge to go, I can't quite get to the bathroom in time before I start to dribble, or you might have complete loss of bladder control. So it's that increased frequency and that urge, in what we call urge incontinence. I feel the urge to go and I cannot get to the bathroom quick enough to control. So that's called overactive bladder. The next one we'll talk about is stress urinary incontinence, and we abbreviate that SUI. So stress urinary incontinence. And this is incontinence, urine incontinence, that's related to physical stress placed on the bladder, causing loss of urine control. So the common thing I hear from patients is I cough, I sneeze, I jump up quickly, or I have to jump, or I get up quickly out of a chair and I lose some urine control. Again, this can be small amounts, this can be large amounts of urine, but those are the 2 basic types of urinary incontinence, the overactive bladder, and then the stress related. You can also have mixed incontinence, which just means you have symptoms of both. So normally when I listen to these webinars, which you may be as well, going through your brain, like thinking like, oh, I hear myself here, I hear myself in these symptoms. You may have symptoms of one or both. And then the final thing I'll say about incontinence is urinary tract infections can mimic a lot of these same symptoms. So if you have sudden onset of these symptoms, or obviously pain or burning or other symptoms that don't fit into these, definitely, talk with your PCP and get checked for a UTI, because the symptoms can be mimicked. So now I'm going to break those down and talk about overactive bladder specifically and what you would do for something like that. And then at the end of this part, we'll talk about stress urinary incontinence, and then we'll kind of wrap up things. So overactive bladder, again, those symptoms are the urinary urgency. So I have to go frequently. So it's increased frequency of urination, and you might have increased nighttime urination, but it's definitely that's increased in the amount of the times I feel like I have to urinate, and then you may have some incontinence associated with that. So we call it frequency and urge. Sometimes I like to call it, I heard this at a conference once, someone called it a bossy bladder, which I thought made sense to me. So your bladder is kind of controlling you instead of you controlling your bladder. And just remember, our bladder is constantly filling. You empty it, and in 20 minutes, you could sit down and urinate again. It might not be as much, but it's constantly filling. It's a process. So you can feel an urge to urinate even if your bladder isn't full. So you may have more capacity, but again, that bladder can become bossy and it's telling you you have to go, and you have more room to fill before you have to empty. When you feel that urge, it's not a command that you have to go to the bathroom. You can control it. So your brain can control these urges. And again, you don't have to go to the bathroom every time you feel the urge. So that's a summary of what you'll feel with overactive bladder. And like I said, sometimes I call it a bossy bladder. It gives you a sense of who's in control, and you want to control that bladder. You don't want it controlling you. So how do we treat an overactive bladder? So when an urge occurs and it's been less than 2 hours since your last void, what you want to try to do is distract yourself. You want to stay calm, take a deep breath. Again, try to distract the urge with something different. You can meditate, relax, listen to music. Sometimes I'll have patients recite a poem or sing a song, something that takes their mind basically off of that urge. You could do some muscular things to help decrease the urge as well. And one would be to raise your heels up and down 10 times while you're sitting, or you could be standing and doing it. Sitting down can sometimes help because putting pressure on the bottom may calm the bladder down. And you could do some Kegels, which is a pelvic floor contraction, which we'll talk about in a little bit how to do that. But those are some things you could do when that urge comes and you know it's only been 30 minutes, 60 minutes, 90 minutes since you last voided. And so the goal here is to try to increase that length of time between voiding. That urge is going to peak, and then it will decrease over time if you train it to do so, if you do those things that we just talked about. I recommend people keep a journal noting time of urination because maybe you didn't know when you last voided. So there is some legwork on your end to help retrain the bladder. So keeping a journal noting when you urinated last, so you can look and say, oh, it really only has been 45 minutes. I got this. I can control this. And then the goal is to time your voiding with a goal to gradually increase time between voids. You shouldn't go longer than 4 hours between voiding, but your body should be capable, all things considered, to go up to 4 hours between voiding. And we know our bladder does that at night. Many of us can sleep 4 to 6 hours before we have to get up, or longer before we have to get up and void. Other tips, again, kind of summarizing things and a few other tips for the overactive bladder. Avoid what's called just in case peeing. And I think again, it's one of those things when I say that, you're gonna be like, oh, I do that. So just in case peeing would be, I'm going to the grocery store, I'm gonna pee just in case. Oh, I've got friends coming over, I'm gonna pee just in case. So you want to avoid, I mean, we all do that. I mean, I did that before this webinar because I knew I'm going to be on the computer for 90 minutes and I'm like, I don't have to get up and have to go to the bathroom. So there's times it's necessary, but it should not be a regular routine of your day. Again, not more than every 2 hours. Don't push your pee out. Sit down, let it flow. I'm going to show you a video here in a minute, and you saw those pictures of the pelvic floor. Those muscles are holding your urine in. And when you urinate, you have to relax those muscles and let it flow. You don't want to push it out. So relax and let it flow. Again, consider keeping that urination journal. Track when you go. And we're going to talk about this, some foods that can irritate your bladder, but keeping track of foods that you eat that you might cause bladder irritation. And we'll talk about what those are. So a good idea to write these things down so you can keep track. Again, do not ignore the urge to go for more than 4 hours, and this would be daytime. So we're not looking to extend that length of holding our urine for more than 4 hours. Again, that urge will peak and that will decrease over time if you train it to do so. So you're going to get the urge to urinate, and maybe you're someone who's going to the bathroom every 45 minutes to an hour. That urge is going to come on, and then you're going to try to suppress it with those things we talked about, and then increase that interval of time over 2 to 4 hours. And also know what your triggers are. For some people, running water will trigger the feel to urinate. The thought of having to drive or travel will signal that urge. Or like a key in the door, maybe you came home from work and then you get that key in the door, and for some reason that will trigger patients or people. Sorry, I keep saying patients because I work with patients all day. But a key in the door will trigger the need to urinate. So kind of be aware of what those are and have a plan to how to handle that. Let's talk about fluid and food intakes on overactive bladder. So we'll go through these from starting from the left going across. You want to aim to drink 6 to 8 cups of clear, relatively clear liquids per day, and those are 8-ounce cups. You know, obviously there's outliers. People have kidney disease or certain things that can't have that kind of fluid, but on average, 6 to 8 cups of clear fluid a day. You want to limit your caffeine, and that includes cola, coffee, even tea has some caffeine, chocolate. It's a bladder irritant, and it can increase your urinary urge and frequency. Again, this would be where keeping a journal would be helpful. Maybe you're someone who can have a cup of coffee, but if you have that second or third cup of coffee, you're struggling with controlling the urge. So this is where that bladder journal can be helpful to seeing what maybe triggered your symptoms. Alcohol, we know that it increases urine production, and it also limits our brain control of our bladder. So consider if you're drinking alcohol that you could have more trouble with the overactive bladder. Again, keeping a bladder journal can help you identify foods that may cause irritation. We know carbonated drinks, acidic foods like tomatoes, citrus type foods can cause trouble, artificial sweeteners. Those are all things to consider that potential bladder irritants. Eat enough fiber and drink enough fluid to avoid constipation. If you think back to the slide I showed you, that side view where your rectum was, and how if you're constipated in that area, it's going to put more pressure on your bladder, and it could cause your bladder to feel overactive. So making sure we're controlling the constipation. I hear this a lot. I have patients tell me they limit how much fluid they take because they don't want to have to go to the bathroom. That is not a healthy answer to this problem. Limiting your fluid intake causes what fluid you do have in your bladder to concentrate, and then it can be irritating to your bladder. So let's say you only drank coffee for breakfast, you have 2 cups of coffee, but you don't have any water. That caffeine and the coffee is going to concentrate and cause your bladder to be actually more irritated. So it has a negative effect. So do not limit your fluids as a way to treat overactive bladder. Again, I'm repeating this, but the goal with fluids is not deprivation, but symptom management. Depriving fluids can also contribute to urinary tract infection. So take home message here, don't deprive yourself of fluids. Let's talk a little bit about sleep and overactive bladders. Voiding urine at nighttime or during sleep time for 1 to 2 times is normal. If you're going more often than that, you want to consider those same techniques that we just talked about, that urge suppression. You can also, I just told you not to limit fluids, but you can limit fluids at nighttime. So 6 to 7 p.m., depending on when your bedtime is, but 4 to 6 hours before you go to bed, we tell people to recommend that they start limiting their fluids, maybe just sips of water instead of gulps of water. So limit your fluid intake after 6 to 7 p.m. if you're avoiding too much at night or being awakened too much at night. But make sure you get your fluids, get them throughout the day gradually. Don't wait till supper time to have 4 glasses of water. And the other thing to try is what's called urge suppression, which we just talked about, that happens during the day where you have too many urges to urinate. You can try this at nighttime. So you're in bed, you wake up, and you're like, nope, I just got up an hour and a half ago. I'm not going to do this, or I'm going to try to suppress it. You can do those same things. You can do a Kegel exercise. You can pump your ankles up and down. You can just distract yourself, meditate, relax, say a prayer, sing a song quietly, something like that to try to decrease the urge to go. And then you would gradually increase that time just like you would during the daytime. So that's how you can handle sleep trouble. The next slide talks about the proper position to void, especially for bowel movements. Again, this is pretty personal information, but I think it can be helpful. I know it can be helpful. So again, we talked about avoiding constipation and straining because that can irritate the whole pelvic floor area. So when you are voiding, especially of your bowels, you want to make sure that your knees are above your hips here. And you may need a stool support to make that happen. For people that are a little shorter in stature, and especially most of us have a higher rise toilet now. So if you're under 5'2" or 3", your feet might be dangling or not hitting the floor. And just based on basic anatomy, that's going to be really hard for your bowels to evacuate or eliminate that stool. So think about putting a stool or something like that underneath your feet to raise them up so your knees are just a little bit higher than your hips. You're not wanting those feet dangling. That's going to be hard for you to have a bowel movement, and you're going to strain, and then that's going to cause more issues. So just a side note about that. So that's overactive bladder. We're going to switch topics. So we talked about overactive bladder. We're going to go on to what's called stress urinary incontinence. So let's talk about what that is. Stress urinary incontinence, or SUI, it happens when movement or activity puts pressure on the bladder that the pelvic floor muscles cannot absorb, and thus causing your urine to leak. Examples of the stress can include a cough, sneeze, or laugh, especially when it's unexpected. If you suddenly stand up from a seated position, so you had to get up quickly, maybe the phone rings, something startles you and you jump up. Or when you're lifting or jumping. So jumping jacks, I hear this a lot from my patients who, I can't run, I can't jump, I can't lift anything, anything straining, because then I lose control of my bladder. So that's what stress urinary incontinence is. What do you do about SUI? So again, a little bit different than what the overactive bladder treatments were. You want to gradually improve the strength of those pelvic floor muscles, which I have pictured here, those red striated things, those are your muscles, and that's your pelvic floor you're looking at, so the bottom of the pelvis. So you want to gradually increase the strength of those muscles so they can handle the quote-unquote stress, that cough, that sneeze, that jump, that increased pressure that's exerted on the bladder. I didn't show a picture of this, but think about where your diaphragm is. It's at the top of the base of your rib cage, basically. And when you take a deep breath in, or you cough or you sneeze, that diaphragm's going to extend down through the abdominal area and put pressure on your bladder. So that's why the coughing and the sneezing will do it, because there's a sudden downward pressure from your diaphragm onto the organs in your stomach, and then it goes all the way down to your bladder, and then you have that loss of control. How do you improve the strength of your pelvic floor? Well, basically you do a Kegel, which is a pelvic floor muscle contraction, which most of us have heard that term, but it's named after, I believe, a physician who developed it many, many decades ago. But it's contracting the pelvic floor muscles and holding it for several seconds. It's not as easy to perform as you might think. We're going to show a video about it in a moment. When you do it, though, you want to make sure you're just getting or recruiting the pelvic floor muscles. You shouldn't be tightening your butt cheek muscles, and you shouldn't be tightening your leg muscles or your respiratory muscles. You should still be able to talk when you're doing a Kegel and breathe normally. You want to picture the tightening the area around your vaginal and rectal opening. Sometimes I tell patients, like, you think like you're picking up or lifting a marble, or you're lifting an elevator as you do that Kegel. You want to complete about 10 repetitions, holding for 5 to 10 seconds. You might find when you first start doing them, you can only hold the contraction for a couple seconds. So you would start out with that, and then you'd work up to holding it for 10 seconds and do about 3 sets of those per day. Next, I'm going to show you a video. It's from University of Michigan. It's a pelvic floor physical therapist. She shows the anatomy of the pelvic floor on a model and talks more in depth about the Kegel. It's a good reference, and you'll be able to look at it on your own later as well. So I'm going to try to share this, and Nina's going to give me some feedback if it doesn't work.
The first step to performing a better Kegel is to understand the anatomy of your pelvic floor musculature. This is a pelvic floor model. The very front here are the pubic bones, just so you have orientation where it's at, which are right in the front here. This is the top of your pelvic bones. And then all of this in the red are muscles that encompass your pelvic floor. Your pelvic floor muscles are like a hammock. They go from the pubic bone in the front all the way to the coccyx bone in the back. If I turn the model around, you can see all the red. You can see the muscles. You have a superficial layer, which is your first layer that surrounds the vaginal opening. And then you have a middle layer that compresses the urethra that comes off the bladder. And when that has good tone and good strength, you don't have the leakage that can just come out with coughing and sneezing. And then there's a deeper muscle layer called the levator ani layer. This is the third layer. You can see that muscle layer. If I turn the pelvis in, you can see all the red and where it attaches to all the bony parts of the pelvis. When those muscles contract, it's an upward lift and squeeze, and it closes all of these openings, including the urethra, the vagina, and the rectum. When we have good tone in our muscles, we have good support around those openings, and therefore good bowel and bladder control and organ support. Your pelvic floor organs attach, the ligaments attach up into the muscular walls of your pelvic musculature, and when those muscles are strong, we have good organ support. When they become weak, then things become lax and we can get incontinent and also have pelvic organ prolapse. So when we do a Kegel, especially for a female, we want to think of squeezing the labia together and also squeezing and lifting the anus, kind of like a puckering. You should not feel any thigh muscles contracting or outer gluteal muscles contracting. Conversely, for men, it's a little different. You also want to think about lifting the anus and lifting the musculature without squeezing the outer buttocks, but you also want to think about squeezing and pulling inward in the front. Common tip we use for men is pull the turtle head back in the shell. And so that just means pulling the penis inward towards you. You get a stronger contraction when you contract all three layers together. And that is a proper way to do a Kegel. When you find those muscles and you feel like you can generate a contraction, you want to work up to doing about 10 repetitions with a 10-second hold and a good 10 to 20-second rest in between, and do that a few times a day. You can also practice quick contractions where you squeeze and let go about 10 times in this kind of a rhythm, okay? You want to do your Kegels, like I said, just a few times a day. Once in the morning, maybe later in the afternoon, and then at night. Don't do all 3 sets at once. You'll over-fatigue. Once you've done them correctly, you should gradually feel an improvement in your bowel and bladder control. If you're not finding success with performing your Kegel exercises at home, it may be time to seek more guidance from a pelvic floor physical therapist. I've often found that patients think they're finding their muscles correctly, but they're not, and still need some guidance. So the pelvic floor physical therapist that you will see or may see will help guide you and instruct you in an appropriate home program that will help you achieve your goals. They may also
So that was a little video that I think gives a good demonstration of what the Kegel looks like or should feel like. And just to reiterate what that therapist said, again, you don't want to contract your butt cheek muscles. You don't want to hold your breath. You shouldn't be tightening your leg or thigh muscles. It should just be the pelvic floor area, which can be difficult for patients or people to find. That's where she talked about, like, for some people, they need some physical therapy, and we can certainly help if with that if needed. So let's talk about how you progress. This can get a little bit confusing, but I'll do the best I can to explain to you how to progress for the stress urinary incontinence treatment. So the first layer, the first baseline is, can I do a Kegel? Can I do it correctly? Meaning I'm not holding my breath, I'm not tightening my butt cheeks, just the pelvic floor area. Because we know when people lose control of their urine with stress urinary incontinence, it's not just when they're sitting still, it's when they're active. So you want to build some movement into it. Once you get the good understanding of how to perform a Kegel, you do a progression. And what I like to do is, after patients get the understanding of the Kegel, is I have them do it with breathing. So you would take a deep breath in through my nose. I'm going to exhale through pursed lips, and I'm going to perform a Kegel while I do it. And I'm going to maintain that Kegel or that pelvic floor contraction during my whole exhale. So it's a deep breath in, everything's relaxed. With pursed lips, so you can see it's like I'm whistling. And when I do my exhalation, I'm going to do that Kegel at the same time, and I'm going to maintain that. So it takes some kind of walk and chew gum at the same time type of mentality. You have to really think about it. But that's the first progression after you get the Kegel. And then you're going to add impact, because again, when we lose control with stress urinary incontinence, it's when we have some impact, some force coming through our body, whether that's a cough, a sneeze, a jump, a lift, something like that. So there's lots of options with that, but I have pictures of a few of them. Bridging, most of us have done a bridge throughout our life as an exercise. So it's simply lying on your back like shown in the top picture here, and you lift your butt cheeks. Okay, so you're going to build a Kegel into that. So you are going to perform the Kegel like I have it listed there, and then you're going to lift your butt into the bridge while maintaining that Kegel. And you're going to, again, hold it for 5 to 10 seconds. You're going to work up to that. About 10 repetitions, but we're always looking for quality, not quantity. So maybe you can only do 3 or 4 good contractions and maintain that Kegel at first, and then you work up to 10 repetitions. And I have this on all the slides here with these exercises. Do not hold your breath. That's the worst thing you can do, because when we hold our breath, it puts more pressure on our pelvic floor, and you're negating whatever you're practicing. So you should be able to speak or talk or count. Sometimes I help patients count out loud with this so they don't hold their breath. Squatting would be the next progression. So again, you're going to perform the Kegel. You're going to squat to whatever a comfortable level is for you. And you're going to maintain that Kegel and that squat for 5 to 10 seconds. And then you'd stand back up and you'd repeat it. Again, not holding your breath. Sit to stand. Again, for some of us, when we stand up quickly, that's when we lose control. So you're going to practice it. You're going to sit down. You're going to tighten your pelvic floor, do that Kegel. You're going to stand up. And you're going to stay standing and hold that Kegel again for that 5 to 10 second count. And then you're going to obviously not hold your breath. You sit back down and repeat that. And then once you get the hang of that, what you could do is you could do it quicker or faster. Those, and kind of, again, knowing what triggers your symptoms and practicing that with the Kegel. I don't expect people to have to go around the rest of their life, like every time before they stand up, like, oh, I'm going to do a Kegel. But that's how it starts. And then eventually your body can absorb that stress without having to do the Kegel. Higher level recreational activities, so things like running, jumping, sometimes doing those previous exercises is enough to help it, but sometimes it isn't. So if your symptoms aren't improving with the Kegels and exercise progression, consider being evaluated by a physical therapist that has pelvic floor training. Not every physical therapist does have that training, but you want to, so when you make that phone call to set things up, you definitely want to make sure that your therapist has pelvic floor training. Sometimes a more individualized approach is needed. Sometimes these are helpful, but sometimes you need more individualized help. There are certainly times not to do a Kegel, okay? They're not the answer to every pelvic floor problem. I've had many patients come to me that have struggled with either pelvic pain or urinary incontinence for a long time and were just told by their doctor to do Kegels. And that's not always the treatment for it. So we can't do a one-size-fits-all approach here. Some people have trouble emptying the bladder. They have increased tension in the pelvic floor muscles. And for those cases, a Kegel is not the answer. If you suffer from pelvic pain or difficulty emptying your bladder, Kegels are probably not the treatment for you. So definitely seek individualized attention from a PT or talk to your OB-GYN and have some testing done to try to figure out what's going on. But oftentimes therapy can help, but Kegels aren't the answer. So lots of information. I'm going to do a little recap here before we get to questions. So we talked about 2 types of urinary incontinence, one being overactive bladder or OAB. And the treatment for that, again, is to change our behaviors, suppressing the urge, gradually increasing the length of time between voiding. Kegels can help suppress it. So when you get the urge, doing a Kegel can help suppress it, but it's not the only treatment. You also want to consider journal timing of your urination or food or drinks that irritate the bladder. Know what your triggers are so you can have a plan in place how to help that. Avoid just in case peeing. Make sure you relax your flow when you are voiding of urine. Treat constipation if it's present. And remember, it's not a pressure problem like stress-induced incontinence. So it's not just the Kegel and learning how to handle that pressure, but it's gradually increasing that time between voiding and not letting your bladder be the boss of you. Stress urinary incontinence, we'll recap that. So this is urine incontinence that occurs with physical stress, the cough, the sneeze, the jump. Treatment is based more on strengthening the pelvic floor, doing those Kegels, along with gradually increasing the difficulty of the exercise while maintaining the Kegel. So we talked about the bridge, the squat, the sit to stand. Also addressing the negative bladder hygiene behaviors if they're present, because you can have the mix where you have a little bit of urge and stress incontinence. So if you're a just in case peer or you're limiting your fluids, you want to address those issues as well. To summarize here, bladder distress is common, but you don't need to live with it. You're not alone. We talked about those slides. 1 in 3 women, 1 in 10 men suffer with urinary incontinence. It can be a touchy subject to talk about. People are hesitant, but know that there's treatment for a lot of these conditions, so you don't have to live with it. Don't dismiss your symptoms. Speak with your primary care provider, especially if there's any sudden onset of symptoms that could mimic a UTI or something more serious. For some people, simple lifestyle changes and improved bladder hygiene can improve symptoms. And my final note here is just please use caution with fad treatments. We all know once you look something up online, your social feed is filled with all kinds of treatment. There's a lot of fad out there with everything. Please get your information from reputable websites. I like to use Mayo, U of M, or Cleveland Clinic are the few that I like to find information on, and even for patient education. And I'll send patients to some of those websites for further clarification. That is what I have. I hope you found it helpful. I know it's a lot of information, but Nina will send this back out once it's all recorded that you can review. And I'll turn it back to Nina and let her field any questions.
Thanks, Jen. That was very helpful, and I fall into one of those categories, so I'm going to be doing some exercises now.
All right.
I hate to admit that, but it's happening.
No shame in admitting it.
Right. So it looks like we don't have any questions in the Q&A at this time. If you are interested, we'll just wait another minute or so. What you do is you just take that your little arrow down at the bottom, and there's actually a little button. It's got two little, looks like bubbles, and it says Q&A. You just click on that and you type in your question, and then we'll go ahead and answer that right away while we're here. If you aren't able to do that, you do have some questions, you're always welcome to give us a call, and we'll do our best to get those answers to you. And of course, this will be sent. So since you registered online and we have your email address, this will go out to the group so that they can view it. And then you can also visit McKenzie Health System's YouTube channel, and you'll be able to see it there, as well as all of our other educational pieces and our Healthy Living Together workshops. So at this time, it looks like we don't have any further questions, so I'm going to go ahead and dismiss that and thank Jen again for all of her help and assistance. It's been very educational, and we really appreciate the time that she puts in for community work. So Jen, thank you again.
You're welcome. It's a pleasure. I hope it's helpful for people.
Yep. And you guys have a great day, and we'll see you again.
Thanks, Nina.
Thank you.